Hi, everyone. My name is Amar Dhand, and I'm an associate professor of neurology here at the Brigham and Women's Hospital. I'm happy to speak to you today about social networks and neurological outcomes, specifically about mixed methods approaches. I want to speak on mixed methods because it's an important complement to our traditional quantitative approaches in research. And in my work in particular, it's yielded some very important insights that I would have not gained unless I have done the hard work of asking qualitative questions and using a mixed methods approach. And perhaps for this audience, it could offer a useful means of thinking about how to design future research. What is mixed methods? Mixed methods is integration of quantitative and qualitative data within a single study or research program. It's multiple uses, such as understanding mechanisms of a complex or unexpected quantitative pattern, to develop better measurement tools, and to give voice to the patients that we are studying. There's some typical study designs that my group has used, but are also very available in the literature and yielded some important findings in the literature. One is a convergent design. This is when you do qualitative and quantitative data analysis in the same study. For instance, you use semi-structured interviews as you're collecting quantitative data on certain predictors and outcomes, for instance, in a longitudinal study. Sequential design is another way to do it. For instance, you've completed a quantitative study that's revealed some unexpected or complex results, which are quite common in our work. And then you follow it up with a qualitative analysis to explore and explain the results that are found. This could also be flipped in the opposite direction. Qualitative work initially, for instance, interviewing a series of patients in a pilot study reveals a certain dimensionality or taxonomy to the phenomenon. And then you use that ordering to develop a survey question, for instance, or better sensor capture of the phenomenon in your quantitative study. I find that this approach is actually inherently used in medicine and under-respected. We, for instance, use and think about case studies, which are N of 1 descriptions, as sort of the lowest level of evidence in our medical hierarchy of evidence. And many case studies are not even allowed to be published in illustrious medical journals. But if you look at the history of medicine, case studies are actually some of the most landmark studies in medicine and have set the stage for quantitative inquiry and deeper biophysical mechanistic inquiries. And in their classical form of qualitative inquiry, they're an in-depth description of a single case from start to finish. Here's a classic example that we know well at Harvard. This is Phineas Gage, who was a railroad worker who had a tampering rod that went through his prefrontal cortex and out the other side. He had no motor deficits, no language deficits, but he had a dramatic change in social behavior and personality. The line is Gage was not Gage anymore. And he really opened up the case, opened up our thinking about localization, cognitive neuroscience, and really is an important landmark in understanding the brain as with functions that are localizable to different parts of the brain. So it's an example of a qualitative study that then developed into an entire field. I want to give an example of my own work. We're very interested in pre-hospital delay, the delay that patients and families and friends create before coming to the hospital, for instance, before an ischemic stroke. We've studied these patients not just in terms of individuals, but as people embedded in these personal social networks. And we found two major patterns of social network construction that are mathematically mathematically created or described by graphs such as these. And there's a bonding network on the left in which patients is in a close-knit network with a high constraint. And there's a bridging network on the right in which the patient's embedded in a loosely affiliated network in which there's multiple groupings. And so that creates a low constraint system. And what we found quantitatively was that network size was markedly different in slow arrivers versus fast arrivers, and that it was directly proportional to arriving quickly, so that patients with large networks were more likely to arrive quickly. And then similarly, constraint was also related, in which patients with a high constraint system arrived slowly, and a low constraint network arrived quickly. And we, did the traditional multivariable analysis statistical work, and we controlled for the traditional variables, but we were still puzzled by why this quantitative finding was occurring. And so we followed up with some qualitative interviews. So we, in a subset of patients that we were studying for this research program, we asked them simply, tell me about what happened as you discovered your symptoms and made the decision to come to the hospital. What were the series of events that occurred? And immediately you saw some of these amazing descriptions that was not elicited by our quantitative survey. So for instance, we have a patient number one who was a patient with her husband and grandson, and then the husband called the daughter, and that was the series of events. Patient did not tell her family initially. She argued with her husband, and then the husband agreed to wait, and then finally the daughter called the ambulance after she returned from work. Here's an example of a patient with her niece, who was also a strongly connected person. Patient did not tell his niece initially. He wanted to wait and see what happens. Then the situation did not change, and so he asked his niece to call 911. Here's an example in which a patient was with her husband and then called her sister. Husband and sister did not think the symptoms were serious and confirmed each other's opinions. Patient decided to call the ambulance herself. And here's the opposite. Here were a series of fast arrivers. And this was a patient with a coworker who called his supervisor. So the coworkers noticed that normal behaviors and called an ambulance without discussing with the patient. Here was a person with an acquaintance who called 911 immediately when the patient couldn't get up. And here's a patient with friends patient was playing with basketball with the friends, and two friends noticed signs, and one friend drove the patient to the hospital. And so we came up with a taxonomy. What happens with patients who are slow arrivers? Well, they're in networks that are blinded by affection. The network selectively, where the patient selectively discloses symptoms, the network over negotiates the symptoms, and they socially confirm a watch and wait plan. And this is the opposite in the fast arrivers, in which there's immediate information disclosure, disruption of the tendency to wait, and immediate action. And so we came up with a mechanism that explains the social network phenomenon that we quantitatively observed. And so I want to just finish by saying there are certain advantages to a mixed methods approach, which I hope you would consider in your future research. First is that it converges complementary quantitative and qualitative data. It's a rich, comprehensive data set that's produced a more complete picture of the phenomenon. And by comparing two data sources, it often leads to mechanistic understanding and directionality in terms of what to do next in your research. There are limitations. There's increased complexity and difficulty that requires a multidisciplinary team. And qualitative pieces by themselves are not necessarily respected, and so you need to be presented in conjunction with your quantitative data. But when you do, you come up with a very powerful statement of mechanism and convergent data sources that are leading to the conclusions and claims that you're making. So that's my end of my talk. I'm very happy that I was invited. Thank you, Dr. Smith and the CNOC group. I hope that we can take some questions at some point in the future. Thank you so much. Bye.